Cancerous growths of the large bowel are known as colorectal cancer, commonly referred to as bowel cancer. Usually start as little polyps, pimples on the lining of the inner lining of the bowel, called the mucosal lining of the bowel, and then they can gradually develop into cancers. Well, the mainstay of treatment for bowel cancer is removing the affected section of the bowel. Bowel is a long tube after all, and it's a question of removing the affected section of the bowel with an operation. Now, some patients may need some radiation treatment and chemotherapy, which is, chemotherapy is anti-cancer medication, tablets or injections. And radiation treatment is where special X-ray type radiation is aimed at the cancer. Now, these treatments may be needed before the operation to shrink certain types of tumors, and in some cases after the operation to support the patient or give them additional treatment. The majority of bowel cancer operations can be performed laparoscopically by experienced surgeons. This is keyhole surgery. Laparoscopic surgery is keyhole surgery where small cuts are made instead of big cuts up and down the abdomen. And the operations performed by narrow instruments which can be inserted inside the abdomen and do the operation as if you're seeing the whole of the inside of the abdomen is visible on a camera, on a screen, and the surgeon operates using these fine instruments. This obviously makes the incisions less, the cuts on the abdomen less, allows much earlier recovery and reduced complications. Some people, from a bowel operation point of view, may need to have a stoma. A stoma is when a surgeon needs to bring the bowel out onto the surface of the skin of the abdomen, and then the waste is collected into a special bag called colostomy or ileostomy bags. Now, some of these stomas may be reversible. Unfortunately, some of them may need to be permanent. As I've mentioned, there are a variety of options in terms of treatment. Does the patient need an operation? Is there a need to give them some treatment before surgery, such as radiotherapy, chemotherapy I mentioned? Is there any need for treatment after? If so, what kind of treatment? When should it be given? There are so many options and so many different specialities need to be involved. So many different people with so many different areas of expertise need to be involved. Now, patients are often concerned about how such decisions are made regarding their treatment. And even though the patient usually sees or meets only the surgeon, several specialists make the decision in choosing the right option to persuade, to pick the right treatment option for each patient. This is called a multidisciplinary team. And the decisions are made on the basis of the discussions about each individual patient to decide what's best for them, for that tumor in that individual at the level or the stage that that particular tumor is, rather than just a standard one-size-fits-all approach. Well, most MDTs, multidisciplinary teams, consists of specialist surgeons, people like myself, oncologists, who is a specialist dealing with chemotherapy and radiotherapy, radiologists, these are X-ray doctors, specialists who review and discuss the scans, pathologists who look at the tissue that we remove, either by biopsy or after operations. They look at these tissues under the microscope to determine whether it is cancer in the first place and to determine whether the tumor has gone to the lymph glands or how aggressive it is, so that treatment can be targeted. Specialist nurses from the bowel surgery department, endoscopists who carry out the colonoscopy, specialists in pain management and palliative care. Lots of people are involved in a multidisciplinary team. The actual membership may vary from different hospitals, but these are what we would call the core members in any EMDT. Again, this can vary between hospitals and local arrangements depending on which part of the country or which part of the world you're talking about. Within my own team, we keep the patient and the patient's general practitioner informed and involved at every stage. Our own practice is to review the patient following an MDT discussion and counsel them about the discussion and further treatment plans. Now, these are done usually face-to-face, but because of the pandemic, obviously, we're sometimes forced to do this by telephone or virtually. In our practice, the counseling session is actually quite a long session because this is not just a question of telling somebody a minor diagnosis. This is a big issue. It's a life-changing situation for the patient. And we spend a lot of time, usually a surgeon and a senior nurse from the colorectal department do a joint counseling session in all these cases. But of course, as I said before, these practices can be variable depending on where you're accessing the service. Usually the patient has one point of contact. In the majority of cases, it's the surgeon and the specialist bowel nurse. But this is to maintain continuity and build a rapport with the patient and their family. As I mentioned before, these are from the patient, from the professional's point of view, from someone like me or any of the other professionals dealing with this condition. This is something that we do several times every week, week in and week out. But for the patient, this is a once in a lifetime experience for their carers, for their relatives. And it's much better to have the same face when you're meeting people. You establish the rapport. However, it's very clearly explained to the patient that the decisions that we are discussing with them, that we are communicating to them, have been reached by appropriate discussion with a variety of specialists. Occasionally, in complex cases, and more than one specialist team may need to physically see the patient together. This is avoided whenever possible so as not to intimidate the patient. It's frightening enough for a patient to come to the hospital to see one specialist, but to walk into a consulting room and find there are like an interview panel sitting in front of them, oncologist, radiologist, whatever, that would be very frightening and very, intimidating to the patient. So usually the point of contact is the surgeon and the surgical team, but they are speaking on behalf of the bigger team behind. There's a lot more information on this and other related subjects on my colorectal education website, www.colorectaleducation.com. This is the free site, and once you access it, please go to the patient section where you'll find a lot of useful information, not just patient stories, actual multidisciplinary meetings being recorded to give you an idea of how these decisions are made and how the team interact with each other.